understand. It's now, I don't know, 2 years later from our first line story. The patient has a favorite parking space in the parking lot. They know the front desk people. They know the people in radiology. And they come in and they now have progression of disease on first and second line. What kind of is our goal of therapy now in this PS 1.75 patient that's coming in? Metaport in place, a little neuropathy, skin's a little dry, right? Maybe hair looks like mine. What's our goal of therapy right here?
I think the RAS story drives that and what they got before. So if you have a RAS mutated patient who got full FOX-Bev and full Fury-Bev or whichever, and they're not getting an EGFR agent, they're now in line for TAS-102 or regorafenib. And the drugs were developed in exactly the same schema, exactly the same number of patients, virtually the same benefit, just difference in toxicities.
Is our goal different than it was in the beginning?
It's prolonging that 1.75. It's not shrinking tumors, it's prolonging survival.
Slowing the decline.
Slowing the decline. And that's what was shown in the TAS-102 study, is that dropping from 0 to 1 to 2 was longer in the group that got treated versus placebo. Yeah. In people who got sequential full Fury-Bev, then full FOX-Bev, then an EGFR agent, you now might be in 4th or 5th line therapy. I think in the correct trial with regorafenib, the average was about 4, right? So that's the group we're treating. So I think one of the issues in looking at the benefits of these, quote, last line drugs is some of them were 3rd line and some of them were 6th line. And it would be good to look at the variability in outcomes in those patients.
Does that patient have a different goal? I always think of that patient in the front line wants to be aggressive and wants, that's the language. Is the patient different now? They still want to be cured?
The patient, I think, needs to be a little bit more realistic about what the goals are when we're talking about 3rd, 4th, or 5th line of therapy. Once again, the quality of life is of utmost importance, but really we're trying to help them prolong their survival. And honestly, if we can keep them on with good quality of life, with good outcomes, we can potentially put them on a clinical trial down the road as well.
Right, right. And I think we get a fairly high percentage in our kinds of centers of patients who make it to this line of therapy too. But we all have patients that don't, that get to this point and either from PS perspective or emotionally don't want to do it right. I mean, so there is a fall off where I think almost everybody's getting 1st and 2nd line down.
One thing that what we did at JCO and I was working on it is that we included the protocol in every large trial so that you could look and say, would my patient could have entered this study? And when I talk about TAS-102 or regorafenib, I really try to get people to use that algorithm of how those patients got in the study. Because my feeling is if you're putting a patient who's really a performance status 2 with a low creatinine clearance and bad experiences with other drugs, and you give them TAS-102, for example, you're likely to have less benefit, even less benefit, and more toxicity. And so some patients should not be treated. I think with the newer drugs, you have to be a little bit more rigid about how you treat them.